Welcome, everyone, to the South Asia, the public health response to COVID-19. Thank you to all our panelists. Thank you to all our panelists for joining us from different parts of South Asia today. And we are delighted to be able to bring all of you together, experts in public health in Bangladesh, in India, and in Pakistan, to speak about this very topical theme, which is part of a larger event called the Maryam Forum launch, From Rulership to Leadership, Early Lessons from the COVID-19 Pandemic, and is being held in association with the Institute of Global Affairs and the LSE School of Public Policy. Before we start, and before I request our panelists to make their presentations, may I just say that the LSE South Asia Center has, in the last few months, done quite a few events and published quite a few blog posts on different aspects of this pandemic. And we would request all of you to visit that page whenever you have a moment. Once the speakers have spoken, we have invited Dr. Mishal Khan from the London School of Hygiene and Tropical Medicine to be the discussant and initiate a discussion. And after that, we will open it to the public for questions and answers. To send us your questions, please could I request all our viewers to paste them in the chat room, and we will pose them to the relevant speakers. If there's a particular speaker or panelist you would like to pose your question to, please mention them by name. Otherwise, we will try and collate as many questions and fit them in. For those of you who are watching it on Facebook, you are welcome to paste your questions on Facebook, and we will be checking that as well. Unfortunately, we don't have too much time for questions and answers, but we will try our best to fit in as many. And I will now not take more time, but I will say a couple of things. Those of you who are active on Twitter, the hashtag for this event is hashtag LSE Maryam Forum, one word. And it is now my very pleasant duty to introduce all the speakers, and then we will start off with the presentations right away. Let me begin with introducing myself. My name is Nilanjan Sarkar, and I'm the Deputy Director of the LSE South Asia Center. From Bangladesh, we have Dr. Ahmed Mushtaque Raza Chowdhury, who was formerly Vice Chair of BRAC in Dhaka, and we never miss a chance to say that he's an alumnus of LSE. Professor K. Srinath Reddy is President of the Public Health Foundation of India and is based in Delhi. Dr. Faisal Sultan is CEO of the Shaukat Khanum Memorial Cancer Hospital and Research Center and is based in Lahore. And last, but certainly not the least, Dr. Mishal Khan is Associate Professor in Health Policy at the London School of Hygiene and Tropical Medicine and is the invited discussant to this event. Welcome, everyone. May I begin with requesting Dr. Mushtaque Chowdhury to make his presentation. Dr. Chowdhury, you need to, sorry, Dr. Chowdhury, you need to unmute your mic. Yeah.
Is it working?
Yes, it is. Thank you. Please go ahead.
Okay. Thank you, Nilanjan, for inviting me to this event. It is always nice to be back to one's own alma mater. It is more than 4 decades since I attended this institution, but I clearly remember my time there and my friends and teachers. It was a great learning experience. Thank you, LSE. May I now request Chris to do the screen sharing, please? Okay. I'm going to share with you the Bangladesh experience in respect of COVID-19. Obviously, this is my own impressions and assessment of the situation on the ground. Next, please. Bangladesh has a population of 165 million and a population density of 1122 per square kilometer. Of the three countries being represented here today, Bangladesh is the smallest in terms of population and land area, but it is the youngest as a nation in the region. Bangladesh is also the most densely populated country in the world. The population is young, with a half under 28 years of age. Urbanization is happening fast, and about 30% of the urban population live in slums. Bangladesh has done quite well in socioeconomic terms recently. The life expectancy has risen to 73 years, which is the highest for the region. Bangladesh spends very little in healthcare, unfortunately. The public expenditure is less than 1% of GDP, which is lowest not only in the region, but also globally. Sri Lanka, for example, spends 4 times as ours. The next one, please. Bangladesh had its first COVID case on March 8th and the first death 10 days later. One of the first public sector response was a countrywide lockdown from March 26th. As of yesterday, there are 150,000 cases of COVID-19 identified. In terms of cases per million population, it is somewhere between India and Pakistan. In terms of the tests carried out to identify COVID-19, the Bangladeshi rate of testing is lowest among the 3 countries. Next, please. This slide shows the progression of the disease by districts. The size of the circle indicates the number of cases, and the color indicates the growth. Dhaka, the capital and its surrounding, has the most cases as expected. So has Chittagong, which is the second largest city. Many of the circles are very small, as you can see here, which indicates that the disease is not equally prevalent in every district. Next slide, please. This one shows the positive COVID cases, deaths, and recoveries. The blue line shows an increasing trend in terms of the percent of tests that are positive. Currently, the percent positive has hovered around 20 to 24%. However, the percent of deaths among the positive cases has remained quite the same, as you can see here in the red line. Next slide, please. This one shows how fast the transmission has progressed. It took 74 days to have the first 25,000 cases. The next 25,000 cases took only 13 days. And the most recent 25,000 cases took only 6 days. Next, please. Although a huge majority of cases do not need hospital admission, but some do need hospitalization and critical care. Unfortunately, Bangladesh is not prepared for a major pandemic of the order we have seen in some countries. One of the markers of this preparation for a pandemic is the number of critical care beds per 100,000 population. In Bangladesh, it is only 0.7, lowest in the whole Asia region. In this respect, both India and Pakistan are better prepared than Bangladesh. In the figure on your right, you can find Bangladesh in the lowest left-hand side. While Bangladesh has 7 beds per million population, Thailand, for example, has 104. Next, please. Here in this slide, we have the reproduction rate, commonly reported by RT. It is defined as the average number of secondary infections caused by a single infected person at a given time. If RT is above 1, the rate of transmission and number of new infections are increasing. The calculation here is based on the assumption that the number of deaths reported is correct. If the RT is less than 1, then it means the slowing down of the epidemic and new infections are not increasing. The figure here shows that in the early stage, the RT in Bangladesh was perhaps close to 3, but it has followed an erratic trend afterwards and is now about 1.5. The government, however, claims that the RT is 1.05, not 1.5. Next one, please. This one shows the age and sex distribution of COVID deaths. 78% of deaths occurred in males. In terms of age, deaths happened in all ages. However, about half of the deaths occurred in people over 60 years of age. The next one, please. This slide shows the measures that the government took in containing the disease. It started with the development of the National Preparedness Plan in March. It started testing for COVID from a lone research lab in Dhaka. It slowly decentralized the testing, but still half of the districts do not have any testing facility. The government declared a national holiday on March 26, which lasted for about 6 weeks. During this lockdown, the government allowed shops to reopen and public transport to allow people to go home for Eid holidays. It was unfortunately not strictly enforced. Next one, please. Okay. Can you go back, please? Sorry. The government was prompt in declaring big stimulus packages amounting to about 3.7% of GDP, which mainly aimed at revamping the economy. Only about 1% of the stimulus packages targeted the medical facilities and medical communities. The government also promoted the health and hygiene etiquette of hand washing, physical distancing, and wearing masks through radio and television. The next one, please. The government initiated several important and potentially impactful measures. However, in my opinion, those suffered from many weaknesses and limitations. I will mention a few of these now. Initially, there was a denial in Bangladesh that COVID will ever come here. Even the government ministers publicly declared that the disease won't come to Bangladesh. They said that every preparation was there, should it come. The religious leaders issued edicts that the disease was sent from God for the sinners of the Western world, and it will never come to Bangladesh. The death rate for frontline doctors and other workers is one of the highest due to mainly the questionable preparation that we had. The government decided to go it alone despite call to engage the whole community. The civil society and much of the private sector were mostly kept out. Some NGOs, however large and small, initiated their own interventions, mostly at local levels, and they are working. The government at times appeared helpless in facing the pressures from various vested interest groups. The mosques were kept open for much of the time. The ready-made garment sector, which is the lifeline of our economy in many ways, the RMG sector was allowed to reopen even when the entire country was under lockdown, creating a fiasco and risking the lives of hundreds and thousands of workers. There was none to regulate the faltering private hospitals, unfortunately. There is also a conundrum in data generation. Hardly any data of reasonable quality is available to plan for an effective intervention. the infection data is incomplete and underreported. It suffers from two weaknesses: little access for people in half of the districts, and current data report only for the symptomatic cases. Then there is no information available on the quality of the data and the test that is carried out. There is a lack of coordination both within the various ministries of the government and between the government and non-government sectors. Very few are aware of how decisions are made. The health minister himself appeared helpless when decisions were made without his knowledge. Finally, there are questions about how the different decisions are implemented. There are ambiguities in decisions. For example, the government declared general holiday from March 26. People took this in its literal meaning and left for their village home. Some even thronged the beaches. Ladies and gentlemen, the future will depend how seriously the government take on the crisis and how well they are able to implement the various measures that they decide and undertake. So with these few words, ladies and gentlemen, thank you very much for your patient hearing. And again, thank you, LSE, for giving me this opportunity. Thank you.
Thank you very much, Dr. Chowdhury. That was very useful. I'm sure we will be able to come back to some of these issues and questions later on in the discussion, and I have no doubt there will be some questions as well. May I request Professor Srinath Reddy to make your presentation, please, from India.
Thank you very much. May I have the slide on, please? May I have the slide? If it is not on, I can move without the slide, no problem.
Would you like to start?
Okay, fine. Well, basically, in terms of India's journey with COVID, it started on the 30th of January when returning students from Wuhan in China, that being the initial epicenter of the global pandemic, returned to the South Indian state of Kerala, and one of them was tested to be positive for COVID. But then, while the students themselves were then being sequestered, a group of Italian tourists in middle of February touring North India, Delhi, Agra, and Jaipur, coming in from the Lombardy region of Italy, again, tested positive for the virus, and then on the cases started mounting over a period of time. If you want to look at the stats, which were there on the slide, but which if the slide is not there, doesn't matter. In terms of total number of cases and deaths, we have between January 30th and June 30th, more than 500,000 cases and close to 17,000 deaths. But the point I would like to make is all figures like these will have to be adjusted for the large population size while attempting international comparisons. So when you adjust for India's population size, the cases per million at that time was 423 and the deaths per million were 12.6. As of this evening, the cases per million are 451 and the deaths per million are 13.3. Quite low in comparison to Western Europe, United States, and many other parts of the world. There has been a sharp rise in the cases as well as the deaths after 8th of June, after the lockdown formally ended. But even towards the end of the lockdown, when there were quite a few relaxations, the cases started spiking up. Now, the point I would like to make is that there is variable intensity of the epidemic across India. It would be futile to talk about India as one single country in terms of how the pandemic calendar is progressing. There are several areas which went in early into the epidemic and where we are seeing now either some level of control or still a great deal of concern, particularly in the larger cities. However, there are several parts of India, particularly the rural areas, but also much of eastern India, which has been relatively very lightly touched by the virus so far. So you have many different epidemic calendars across India, and therefore to give a summative figure for all of India would be inappropriate. You can take the slide off now. So India started this in end of January, but even from middle of January, flights were restricted and progressively several measures were taken. Social distancing was advised from February and early March onwards. Sudden complete lockdown was announced on the night of March 24th. And then it was extended after 21 days up to May 3rd. And then 2 more periods of lockdown were announced, but with progressive relaxation and opening also built in. And finally, on June 8th, the All India lockdown ended, but some of the states like Maharashtra, West Bengal have declared that they would like to continue the lockdown till end of July, and Telangana is reconsidering whether some parts of it is going to be locked down. So we are having different calendars even for the lockdown and relaxation across the country, as expected, depending on the intensity of the epidemic. As I said, there are multiple states. Some of them are doing very well. Kerala, which reported the first case, has done remarkably well in quelling the epidemic, though there has been a little fluster recently because of a few more cases, because of some returning visitors from other states. Nevertheless, Kerala has had a remarkable record of success. The states of Andhra Pradesh, Odisha, Punjab, Goa, and Rajasthan have done quite well. The states of Chhattisgarh, Jharkhand, Bihar, Eastern Uttar Pradesh have been very lightly touched. Northeast, except Manipur, also has not had too many cases. Now, why is this? It is because the more economically well-developed states of India, with large international airports, large numbers of returning foreign travelers, both Indians as well as non-resident Indians, or even some of the foreign visitors arriving through those airports, brought in the virus, their primary and secondary contacts spread it, and therefore the virus radiated from there. Eastern India, but for Calcutta, doesn't have a large international airport and doesn't have the same level of influx of international flights or visitors. So it's understandable that the geographic spread has been varied across India. And it is a bit ironic that unlike many other diseases, the poorer states of India have been better protected from the virus than the richer states of India, the exception being Madhya Pradesh. Now, the states which are still battling the virus are Maharashtra, particularly Mumbai, Pune area, but where there is some improvement. Then in terms of Gujarat, we are seeing a problem. Madhya Pradesh, Delhi, Telangana, Tamil Nadu. But as I said, Eastern India has been very lightly touched. Why is it that we have had low mortality rates? The younger age of the population, as well as the large rural segment of the population, where there is much less mobility of the people as well as of the virus, are probably protective factors. Other putative factors that have been invoked, like the record of BCG vaccination, polio, and MMR, etc., are really hypothetical and do not yet have any proof behind it. But we also are battling several other problems that, despite the younger age, in urban areas in particular, we have a high level of comorbidities like hypertension, diabetes, coronary heart disease, and in the poorer sections, we have a high level of malnutrition as well. So given this high burden of comorbidities, the age itself will not be a fully protective factor, though it has played a role in some degree of protection. Our weak health systems with less than optimal doctor to population ratio of 1:1,511, of nurses of 1:670 is again a problem. But again, it must be reminded that this is an all India figure. There are several states which are very poorly populated in terms of their health system and health workforce. Therefore, the variability of health system functioning is going to be very different from better placed states like Kerala and Tamil Nadu or Andhra Pradesh than some of the states in central and northern India. Of course, we also recognize that some of the cities like Delhi have suffered not only from the large influx of foreign tourists and the spread, but also from problems related to mixed governance, where the power between the center and the state governments and the local municipal authorities and the lieutenant governor has left a lot to be desired in terms of coordination. And perhaps Delhi is a case where administrative coordination also added to the problems of the virus spread. But we also recognize that we have had low levels of testing to begin with, but with a fair amount of call for greater self-reliance. Apart from imports, now we are producing a lot more of testing kits. Our PPEs were in short supply, as were ventilators, but all of these have moved into a faster gear, and there is now sufficient access now. With that, the testing rates have improved. Earlier, the testing rates were pretty low, and now we have not only the RT-PCR for nuclear testing, but also the antigen testing for rapid testing, and the antibody testing is being used essentially for serosurveillance studies across districts and across containment zones and cities. But the serosurveillance in districts has only shown antibody prevalence rate of 0.73%, which means that at least as far as the smaller towns and villages are concerned, viral exposure has been very limited. Now, the hospital beds were in short supply, but fortunately now we recognize that intensive care beds with ventilators are not really required for most of the patients. Therefore, the focus is now on increasing not only the isolation beds, but also general hospital beds with oxygen supply, and also keeping the milder cases for home care and home isolation. Therefore, some of the pressure on the hospital beds, which has been seen initially, may ease as we move along. Of course, one of the major issues has been the federal system, where the states have now to take much greater role, and health is anyway a state subject. But while in the earlier part of the epidemic, particularly the first two phases, it was the center which was totally in command. Now the states are having a much greater role to play and a responsibility attendant with it. And we are seeing different levels of governance and different levels of performance. Therefore, the South Indian states, which have a much better governance, are doing much better even now, apart from the advantage of having better health systems. But we all are having to battle the low levels of public financing and the neglect of the healthcare sector and the public health system, which has long plagued the Indian public health and healthcare systems. So you cannot suddenly have a very efficient surge response when you have not had a functioning, effective and equitable health system in the steady state. So we are now scampering to try and build up our reserves as much as possible. Some of the states which had invested more in public health as well as in healthcare system, and particularly in the public sector, are doing much better, whereas the states which have not done so are challenged. But the real challenge is yet to come, because most of these states, which are the poorer states, more rural, with poorer health systems in central, northern, and northeastern India, which have so far been relatively protected from the virus, if we can continue to protect them, then we'll gain an upper hand of the virus. On the other hand, if we let slip and let the virus gain control over these areas, then the weaker health systems as well as the weaker governance systems will have a big challenge on our hand. Therefore, we'll have to wait and see what happens. But one beneficial impact of this is far greater public attention to the whole health sector. Public health has gained far greater visibility in the media and the political arena. And we are hoping that also with a greater focus on equity, despite the fact that the migrants, workers were very badly treated, now there is a greater emphasis on looking at why are the slums there? Why are the migrants treated badly? So there is a greater discussion on equity as well. So we are hoping some of the spin-off of this will result in a greater resourcing and strengthening of our health system, as well as a greater emphasis on social and economic equity in our health system because we recognize that with glaring inequalities, we cannot deliver effective health care. And COVID is a wake-up lesson for that. Thank you.
Thank you very much, Professor Reddy. That was very, very informative. May I request Dr. Faisal Sultan to make his presentation from Lahore, please, and then we'll come on to the discussion. Dr. Sultan, please go ahead.
Thank you very much. I hope the slide is visible.
Yes, it is.
Okay, fantastic. Well, first of all, thank you very much. You introduced me in context to my day job at Shaukat Khanum, but for the last 3 months, I've been on leave from there and parked as the Prime Minister's focal person for COVID-19 in Islamabad. And so some of what I will tell you will be from that vantage point. So as far as the fundamental outline, we're going to talk a little bit the way forward. As far as initial tests, the tests done so far are concerned, about 1.3 million. Per million tests are 6,300 approximately. And so far, we've had 217,000 known cases. Deaths 4,473 so far, and the per million death rate has been 21. Now, some key trends. As far as the cases were concerned, I have these 4 panels. We'll quickly run through them. As far as from February, 25th of February till the present time, we've had a gradual and steady increase in cases, which
Dr. Sultan,
so far.
Dr. Sultan, yes. I'm going to interrupt you. We are going to make your video invisible because what's happening is that the video camera is coming on top of the slide, so we cannot see the entire slide. If that is fine with you. You can continue to speak.
I can get rid of it. How's that? Does that work?
No, we can still see you. Chris, do you want to try? And yes, and could I just announce that everyone who's looking at the slides, if you can minimize the viewing box for the video, you'll be able to see the entire slide, and the slides are very, very informative. So please do. Dr. Sultan, please go ahead and speak now.
Okay, so the panel on the top left is, of course, tests, those done and those that are positive. So we reached a max of about 30,000 tests a day around mid to late June. And as far as positive tests are concerned, for a brief period of time of about 5 to 7 days, we were registering over 6,000 new cases per day. We seem to have had a decline in the number of positive cases in the last week to 10 days. And while we are looking to make sure that this is indeed a real decline and not caused by other factors, we do think that there is possibly a little letdown, but I think the data from the next few weeks is absolutely crucial. The panel on the right is an estimation of Pakistan's reproductive number, or not. And we think that we are at about 1.31. There have been various periods. We started out in early April at about 2.5. We came down a fair bit, but then again, we had the post-Eid effect and went up to nearly 2. And then we've been step laddering down gradually since that time. The graphic at the bottom left, of course, shows mortality trends. We've almost had a step laddering there, across many weeks. We reached a peak, as best as we can tell, of deaths of 153 around the 19th to 20th of June. And it seems that we may have had a little step laddering down as well in the last week or 10 days approximately. But really, these are relatively smaller numbers, and it is very, very important to watch this for the next week or two before we can say with some confidence that perhaps the numbers have come down. The panel on the bottom right is the positivity rate. The blue bars are, of course, the daily number, and the orange line is the 3-day rolling average. And we seem to reach a peak in early June of around 23%. And from then, we have had a steady, small decline for most days, except the last couple of days. And I should tell you that there is now a little bit of difference in the numbers that are coming from different provinces. So that is something that needs to be followed. So the crux of all this, all these 4 panels is that as best as we can tell, there may be a little letdown as far as the growth trajectory is concerned. Now, we talked a little bit about how the hospital system filled up. Starting from the 16th of June. Okay, let me just explain the bars a little bit. So the blue bars are people on oxygen, red are those on ventilators. This is total numbers on a given day, sort of a time slot for a time snap for that day. And we reached a maximum of about 3,500 on the 16th of June. And for a number of days, that total number continued. Starting the 18th June, we started to split the data between low flow oxygen and high flow oxygen to try to see if people graduate up or down across the different categories. And it seems to me that from the 19th of June till last evening, we may have had some decline in the total number of people who are who require oxygenation of low flow, high flow, or through endotracheal intubation mechanism. Now, we did have, again, as expected, in early June, there was a fair stress on the system. But at the present time, these are the COVID dedicated ventilators occupancy across a number of cities. And as you can see, a couple of cities still have occupancies above 50%, Islamabad and Peshawar in particular. But it seems to be that this number is gradually coming down. Okay, we had some queries about cellular access. About 3/4 of the country has cell phone connections. The annual total subscribers are, of course, 160 million. Total cellular coverage is about 90%. But when we look at data access, about half of the previous figure, actually have a 3G or 4G connection. And we think that about 42 million people have smartphone usage. This, of course, ties into our ability to impact and help on interventions. Now, challenges. I think one of the most important challenges that we have had is the devolved federal structure. We have provinces, and health as a topic, as a subject, has been devolved very, very heavily down to the provinces. And therefore, at the beginning of this outbreak, the system really did not have all the requisite structures required to have a coordinated response all the way down from provinces to the federal headquarters and back down. So the governance structure did lead to some challenges. We dealt, of course, like many developing countries, with an inherently weak health system, and then to build it up, building the plane while flying kind of situation also challenged us. There were issues of data flow and generation and creation of data, a little bit more on that. Of course, communication with the public, with healthcare workers, I'll talk a little bit more about it. And finally, implementation domains. So as far as data challenges was concerned, first of all, data governance. Who owns data? The different architectures and structures of disease reporting systems across 6 administrative domains, provinces, and so on. And a non-existent inherent flow of data system was one of them. So as far as the flow itself was concerned, we really needed to have accurate, timely, and live information on all the labs being reported. So this had to be built. We actually piggybacked onto an existing system that existed for polio, and that's been really a success. We do have live data coming in from over 100 labs in real time across different provinces. And the nice part is that people at the labs punch in data into provincial dashboards where they exist, and they talk through APIs, etc., directly onto the main dashboard. We also had to, first of all, have a quick assessment of the oxygen beds as well as ventilators, where they were, in what numbers, how it mapped to available manpower, nursing, doctors, etc., the availability of personal protective equipment in all these places, and of course, the very crucial data flow in countries where you cannot have very large per million testing capability, the reliance on accurate death data. And so a lot of effort had to be put in to make sure that indeed we were capturing deaths accurately and that they were being correctly labeled, neither over-labeled nor under-labeled. The other challenge in terms of data flow has been the requirement of central visibility of capacity utilization. So larger cities, understandably, as they started getting filled up, the go-to hospitals, major hospitals, popular hospitals in each of these cities obviously get filled up first. So because of this uneven utilization, it inherently leads to panic and fear. So we needed to create the central visibility of available capacity across the entire country, and visibility of this both to dispatchers of emergency systems. Two of the provinces have fairly robust EMS, and the other provinces had a mishmash of systems. And so to make sure that everybody got this visibility required some effort. Then, of course, we needed to put in effort into data analytics, both for modeling as well as to create system to contact trace, and then to generate information on emerging and existing hotspots. So these were data-centered challenges, and I think many of them have been met, but I think there is some ways to go as well. The other issue, of course, was when you start out with a weaker health system, to build it up in real time is another challenge. We started out with a capacity of 400 PCR tests a day. The current lab capacity is over 50,000, and in a few days we ought to be over 75,000. And so this required really a coordinated, systematic effort between provinces, individual private labs, public sector labs, non-profits, and so on, and all to be plugged into a single system. I think this is the beginning and the making of a future robust Centers for Disease Control, and I think reasonably happy on where this is going. It has been tough going, but I think this is something which is a bit of a success. The build-up on oxygenated beds and ventilation again posed challenges because, of course, as far as ventilators are concerned, they were not in ready supply. And so we needed to first buy where and what we could, repurpose what we had, and of course to kick off the process for making our own. As far as oxygenated beds are concerned, these were a little bit easier to create, obviously, but nevertheless, one had to also look at the raw supply of oxygen, the distribution systems, and how to coordinate across that domain. We had extreme shortages of PPEs in the beginning, especially for things like N95s, but fortunately, we've gone from shortage to surfeit. I think our industry really reacted very positively to it. And today, I think this is really essentially a non-issue, barring a few items here and there. And mostly those have to do with the distribution or effective distribution issues than anything else. Ventilators, as I mentioned, we're actually in a slightly happy situation that indigenous production is starting indeed, and there are a number of prototypes that I think have tremendous potential, and I think this is also going to kickstart some of the industry. Then, of course, you can't build healthcare workers right away, and a number of initiatives have been taken all the way from training people as well as from online initiatives to actually connect capability to where it is required. So this has been a work in constant progress and has really stressed the system, but I think we have, also learned to not let go of the opportunity and to actually utilize to learn from the crisis. The other major challenge has been of communication. Now, I think everybody has faced this. This has been information, misinformation, stigma, and I think with the varied flows of information, misinformation that come from in today's world, this has been really a hard battle to fight. The public perception of threat has been very polar. On one hand, we have had rural populations who were generally spared and really felt that this was an overblown and overstated case. On the other hand, we had urban populations, better educated and with better access to experiences in the West, who felt that this was a great threat and that enough was not being done. So we almost, you had in one country more than one set of people. Then, of course, as far as guidelines were concerned, the other challenge in communication has been coherence and credibility. When you have major top-ranked international journals retracting and watered down, backpedaling publications and major organizations changing guidelines from all the way from PPE to usage of one thing or the other, this has also eroded the credibility of what are essentially credible organizations. And I think this has been another communication challenge to make sure that people do not then buy into all sorts of nonsensical treatments that really don't work and are potentially harmful. Then, as the health workforce at the front line, like many countries, we have lost health workers. And so, of course, there is a fear and backlash and a growing sense, there was at a time a growing sense amongst healthcare workers that while they were facing the brunt of it, not enough was being done to shut down for extended periods of time. And so therefore, they had to be engaged, encouraged, and made sure that they had adequate protection and training to be able to take this on, in addition to being recognized and sort of taken care of. God forbid they did face illness or death even. Now, implementation. Because of the devolved structure, implementation has also been a challenge. Every province, every administrative domain ended up interpreting the threat and their response accordingly. And so one important thing to do was to have the National Corona Operations Center. And I think that's been a very crucial bit to stitch all this together. And I think we would have been in a much worse position had we not put that in place in late March. Unfortunately, because of this central structure that meets every single day, takes on the provinces online, when we have people literally across the entire spectrum coming into it. Interestingly, of all the provinces, various provinces have different and opposition governments, and so this has been a place to try to come together on the medical, epidemiologic, public health, and political response to it. Of course, one of the major juggling acts has been the difficulty of balancing disease prevention and its societal impact. We've had the triple crisis, of course, of health, and not just corona, but the impact of the lockdown, which we had a shorter lockdown, say, relative to what India did. But from around the 23rd of March onwards and so we were worried on the impact on the health delivery systems itself, from drop in immunizations, lost opportunities to treat things like tuberculosis, and of course, impact on maternal health and so on. Of course, poverty and the food supply was also a major concern, but I think fortunately, because of this coordinated structure, much of this was sorted out. We had the SAS program, which actually delivered cash to the poor, and so a lot of amelioration was possible through that end. We're now facing a situation, of course, and this is a challenging of tailoring of the lockdowns. And obviously, everybody realizes, blunderbuss and broad, blunt lockdowns really cannot continue. And these restrictions now need to be targeted and more nuanced. And I think they're not easy to do. There is always enforcement and administrative fatigue in doing this to a fine degree, and this whole balance of doing that without really disrupting life in general, I think is going to be something that we will continue to deal with. So what's ahead? We do need to de-escalate. We need to be able to walk out of the corners, all of us. The whole world has painted for ourselves because that was the need. And so now one of the challenges and of course now is educational institutions, all the way from primary education to university and professional universities and colleges. And so how to do this and in what sequence and what cadence, and this is currently being worked on and evaluated based on available data. And of course, there are other industries that are suffering, and at some point or the other, they do need to be addressed, like restaurant, hospitality industries, and other industries that have suffered very badly. Travel, international travel, of course, will remain a challenge for I think, weeks and months to come. How this works out, how the international community will collaborate and work on what will essentially become travel passports is something that is yet to be seen. Whether we face a wave or waves or wavelets, or whether this is going to be more a whack-a-mole kind of situation where rural or smaller centers now come up and have their own little mini epidemics, as Professor Reddy said, large, complex, populous countries cannot be seen as a single container, and really the individual smaller containers will have their own rhythm and trajectory of their mini epidemics. So this has got to be seen, and therefore this business of smart lockdowns based on signal of cases is crucial and important. Then, of course, the development of pharmaceutical interventions. This has been, of course, a work in progress.
Dr. Sultan.
Yes.
Sorry, if I could just request you to conclude.
Yeah, we're right at the end. So, and we also need to look at the impact on NPI, especially in low resource settings. What the winter brings, we do not know, and how and when and exactly in which way to deploy vaccines when they come. So that's where we are. Thank you very much for your patience.
Thank you very much. Could I request you to turn your camera on as well? And thank you very much. I'm sorry I had to step in between, but I did want to give Mishal a bit of time so that she could, bring all our thoughts together. Mishal, do you want to go ahead straight?
Yes, sure. I will try and do my best. Those were excellent presentations and really summarizing the situations and the challenges across the country as well. So I was making some notes as everyone went along to highlight some of the common issues. I think there's a lot that we can learn from each other. And certainly my personal position on many of these issues is that countries that are similar in terms of health systems and income status have a lot to learn, and often much more than by looking towards higher income countries. So going through some of the common themes, India, Pakistan, Bangladesh all had advanced warning in a sense, because started in China, came to Europe. So there was that time to prepare. And what I was observing in some of the comments was across the population and some of the policymakers, there was perhaps to some degree, a sense of denial that this might happen, or it might be quite as severe as it is elsewhere. It seems commonly found that places that had an airport, or sort of the bigger cities, are more affected, and rural areas are less affected. And I think that actually even presents an opportunity for protecting those areas. There were common themes in terms of deaths of frontline providers, which remains a challenge. The role of religious leaders particularly came across in Pakistan and in Bangladesh, and their role in wanting to not have their institutions shut down. Similarly, issues with keeping some of the core industries such as factories closed, and that was something that couldn't be done for a long time. And now we heard from Dr. Sultan pressures on having to naturally open schools and education institutes. So common challenges about how to open up safely. Another common theme is the role of private hospitals and private providers, and the challenges of regulating them and making sure that the role that's played is optimal. And that's something that's across all countries need to be figured out. And finally, the issues of data quality, both in terms of what's being measured and also who owns it and the coordination. And that actually leads me to one question that I'd like to pose for all of the panelists, which is around, what data can we be using to monitor progress or localized outbreaks? There's concerns with testing data, both around the stigma and whether people will come forward, and also completeness. Initially, we were in many countries relying more on death data as being perhaps better than as an indicator than testing new diagnoses. But then with increasing reports of stigma and people not wanting to report deaths as COVID, or have people who passed away be tested for COVID, where does this leave us with the reliability of death data? So that's one of my questions. And then I had another question about, because there was a common theme that I was hearing, which was that we cannot have a surge response when health systems are so weak, and that's absolutely true. Where there's been weak health systems, as I said, you can't, you're trying to fly the plane while you're building it. So now that this crisis has happened, and hopefully, at least from my perspective as a health policy person, it's really clear what an important role health and health systems play. Do the panelists think that the importance given in domestic budgets and the political priority given to health will change going forward? Or do we think that after the next year or so, when this issue dies down, will health again go back to being much lower on the priority list than it should be? So those are two of my questions, and I have more if there's time, but I don't want to allow others to ask questions too. So my first question was about data and what indicators we can rely on, and the second was health and its importance going forward.
Okay, great. Thanks a lot, Mishal, and thanks for being so tight with time. I'm really sorry, but we are racing against time. Could I just add to it that we've received a few interesting questions on Facebook as well as on in the chat room. What I'll do is I'll simply read it out. And then each of you can include the answers in your answer to Mishal's questions. So a question for all three panelists is, what are the possible policy implications and outcomes of this in each country? That's one question. The second question is, and this is from Sunil Kumar, who's in the department, teaches in the Department of Social Policy, is, and again, for all of you, is that apart from health, in the post-COVID scenario, what else do you think is going to change in terms of social inequalities? And an attendant element of that is that as over here, here in Britain, in England, in the West, in other countries in the West, is there any data or evidence to demonstrate that particular groups of people have been affected more, especially in terms of mortality? For instance, here in England, the Black and minority ethnic groups have been. So in India, is it, Professor Reddy, is it as if the Dalits have been affected more? So is there that element to it? We also have one question from a student of ours, and I'd like, there are two students, and I'd like, one is for Faisal Sultan. This is from Nina, who's an LSE student. Could you briefly develop the use of internet, the point you were making about cellular access, etc., and the challenge of limited amount of healthcare workers, effectiveness of this and the limitations of this? And a question from Shahbaz, who studies in Delhi, and this is for Srinath. This is on plasma therapy and the results of it, and how much difference do you think, something like a plasma bank, etc., would have made, etc., etc. I'll stop now. And shall we go in the reverse order? So Faisal, do you want to speak first?
So I think you ended up muting yourself in the last few seconds. So I assume you want me to address the data question first, and then we can talk about the internet. I think we will have to evolve and change with time as to what data really we can use and what is reliable. Obviously, starting out, deaths were a very important data to look at. It still is, notwithstanding the concerns about stigma and so forth and underreporting, but I think it still provides a very important insight, especially if you have schooled your health system well in the need and methodology of how you're actually going to label a death as a COVID death. There are challenges there as well. So I think that's one. What we've learned is also the percent positivity coming out of the test, because this is a large data set, tens of thousands of tests coming out a day. And so across time, minor variations from day to day notwithstanding, across time, that is an important benchmark to look at. The other one that we found very useful is the fill up of the health system. Because we do now have a fairly complete picture, I think those on oxygen and ventilators, as they go up and down, I think we found that to be a useful one. On internet, of course, I think we've been able to leverage the use of the net to reach out to healthcare workers, both to assist where decision making was required, also to create these web portals to assist in helping the public at large connect with the physicians who had volunteered their time to at least enable a little initial guidance into the system. But for more sophisticated stuff, I think it's a bit harder to do.
Great. Did you hear the question that was posed to us from a student of ours, Faisal, to you? I can reread the question.
Go ahead.
Okay. This is from Nina, who's a student at LSE, and talks about internet access and the use of internet in the context of limited amount of healthcare workers. And the question is the effectiveness of this, that is in a cellular access, limited by issues with internet access in certain areas, or is there a a wider pattern, a wider issue that we are unaware of and is specific to Pakistan. Part of it you actually covered when you said that, of the people who have cellular access, only a percentage of them have access to 4G and etc. So that was one. And the other is there's a general question for all of you. So if you could briefly answer that, which is about future policy implications and whether or not particular sections of society are more affected. What is your feeling?
Who's first? Me? Okay, I'll go
yeah,
first.
Yeah. If you could just finish and then we can go to the others.
So, right. On the use of internet, of course, I think one of the advantages so far has been that, as other speakers have also alluded to, primarily this has been a disease so far of larger centers. And therefore, the acuteness of the need to project expertise distantly really hasn't arisen so far. But I think it will. I do feel that the second wave or wavelets, if you will come from smaller centers, and I think will challenge smaller hospitals and districts. Fortunately, in Pakistan, virtually all tehsil, the smallest sort of administrative district hospitals actually have net access. So I don't think that would be the limiting factor. The real limiting factor will be the available expertise that you can actually provide effectively. It's one thing to go on the net and see a patient or be given data and make decisions, but I think to do this effectively, especially for very unwell patients, is going to be tough. On ethnic minorities, we haven't really seen any major difference. A couple of Jammu and Kashmir and Gilgit-Baltistan have actually had low numbers overall. The populations are smaller, but also the numbers even adjusted for population.
Oh, I think we've lost.
Fully in the conjecture, I won't say more.
Dr. Sultan, we lost your connection in between towards the end when you were talking about Gilgit-Baltistan. Could you just repeat that point quickly? I think we might have lost him again. Shall we go to Srinath? Do you want to take your questions, please?
Sure. Firstly, as far as the data are concerned, we need several sets of data. Deaths per day.
Adjusted for population.
Hello, yeah. Deaths per day are going to be the most important element. And as the death count keeps coming down, we can be more confident that we have turned the corner. But certainly, the case positivity rate among the new tests being performed would be helpful, provided the testing criteria are standardized quite clearly and do not vary from week to week. But we also need to supplement it with syndromic surveillance, which is symptom-based, recognizing that tests have false positives, false negatives. We also need to ensure that we have symptom-based household surveys with syndromic surveillance, and of course, the hospital data on the number of cases requiring intensive care. All these four sources of data need to be collated together, but ultimately, deaths will remain the critical indicator of whether we are really turning the corner. Then in terms of actual usage of telemedicine, telemedicine has actually been permitted now for consultations, but the greater use is not so much for COVID, but for non-COVID conditions which have been neglected during this period, like hypertension and diabetes management, etc., are now being permitted by a liberalization of the telemedicine regulation in India, and therefore many of the non-COVID cases which could not get the attention are benefiting from it. But certainly COVID too could. Plasma therapy is still experimental. It is being used, but the large trials are on internationally. But till that time, on compassionate use, plasma therapy has been used, and now plasma banks are being started in different parts of India, and we'll probably see trials in India as well, but certainly trials are going on elsewhere in the world. In terms of policy implications, I think one of the important elements is a definite recognition that public health is very important, and especially primary health care, not just hospitals with ventilators, that we need a larger health workforce. And the 15th Finance Commission of India, which has been looking at how to actually bring in greater allocations to health, both at the center and the state levels, has called for a fresh review of its recommendations because of the COVID situation and wants to emphasize again the need to rebuild a robust health system. And I think that is a recognition that has come not a day too soon. The other element is a greater tilt towards self-reliance. A lot of our equipment was being imported from outside. With the breakdown of supply chains, I think India has realized whether it is equipment or vaccines or drugs, we have to really ramp up our own resources and produce internally rather than be dependent on tenuous supply chains which may break down in a pandemic situation. Then in terms of social inequalities, right now it's much more of an urban phenomena. The urban poor are certainly inconvenienced both for COVID care as well as non-COVID care. But right now, differential mortality patterns are not yet being evident in terms of income inequalities, though certainly the kind of attention that the poor will receive in terms of testing and treatment is going to be somewhat different. But so far, because it has come in through foreign travelers as well as their contacts, the upper income strata have been substantially affected initially, and the lower income strata have been relatively spared, but we cannot be confident that's going to remain the situation for long. But certainly in terms of non-COVID health conditions, the current preoccupation with COVID care is greatly disadvantaging the poorer sections, whether it is antenatal care or institutional deliveries or other forms of care.
Okay. Okay. Thank you very much. Dr. Chowdhury, if you could answer the questions that I read out, and if you could be brief, we'll have a second round later on. Could I, before Dr. Chowdhury, before you speak, could I apologize to the audience? We have questions raining in absolutely from all the countries, and we won't be able to accommodate all of them. But what I hope to do later on is that, because we have to finish in 8 minutes from now, and what I hope to do is that I will send the questions to respective speakers and get their answers and get back in touch with you. So Dr. Chowdhury, if you would speak now, please. You need to unmute your mic.
Sorry. Thanks, Nilanjan. I'll try to touch on a few questions that have been asked. And then the first one that I want to speak is about the data. And obviously, death is an important marker. But in a situation like Bangladesh, we don't have good vital registration system, which sort of we have something called the sample vital registration system, which is incomplete and also very faulty, and so that's not very reliable. We also have a disease surveillance here, but that's also not complete, and also there are questions about the quality as well. So under that circumstance, I would think that the surveillance of COVID-like symptoms would be a good thing to do, and that can be done even by lay community health workers in the village. So which can be very easily and with so inexpensively done. So that's about data about the policy outcome from the COVID crisis. We just had the budget for the national budget, and there was a lot of expectation that this budget will see a huge increase in health spending. There was some increase there, but what is missing is that this additional money that is there, how that money will be used. There is no mention of that. There is no discussion about that because everybody felt that this is an opportunity to really sort of revamp the whole health system and really make it more pro-people and pro-equity and so on. But there is hardly any interest in the system to really talk about any reform, unfortunately, and people have been talking about the post-COVID health system, and there has been a lot of talk about universal health coverage. So there is a huge demand for that, but it's still at the early stage. On the changes that is expected in terms of inequalities in which sector, I think the major change we will probably see, unfortunately, in the education sector, because in a country like Bangladesh, we have been able to really achieve equality in terms of the girls and boys going to school. Even the enrollment rate was more than 90%, which means that the poor children had equal opportunity to go. But this is something which I think will really sort of be affected. Thank you.
Would you like to say something about whether minority communities are more affected?
We don't have much data on that, but what we have is that we, as I mentioned in my presentation, there is a large population in the cities who live in slums, who are kind of a community by themselves. But what is the riddle is there that there is hardly any report of death in the slums from COVID, and there are also very few reported COVID sort of positive cases in the slums. So that sort of gives a lot of raises questions about how this virus is behaving in different populations.
Thank you. Could I say to our audience who are sending questions, for those we've almost run out of time now, but if you could email your questions to South Asia Center at lse.ac.uk, we will forward them to individual panelists and get you the answers. I know there are people from Karachi who are writing in. I know there are people from different places in India who are writing. Sabah Gul, I can see several of your questions. And I also know there are people from LSE, and part of our idea is to address this. Mishal, I would have given you another opportunity, but I cannot let go of this panel without saying one thing. In as much as we appreciate very, very much the frankness with which all of you have presented, done your presentations today, I do, living in England, living in London, as Mishal does, feel the need to say that even with a very, very good public health system, we haven't really done very well. So while in South Asia, the public health system and its infrastructures aren't as advanced as they are in England in terms of their establishment and in terms of their reach, even with such an established system, as you very well know, the number of deaths in Britain have been amongst the worst in the world. And I think there is something to note and to learn over there. It remains for me now to thank all of you for your time. I know in some parts of the world it is now very, very late. To thank all our audience, but especially Dr. Mushtaque Chowdhury from Bangladesh, Professor Srinath Reddy from Delhi, and Dr. Faisal Sultan. My apologies, I said you are in Lahore, which is your day job, but from Islamabad. And Mishal, just because you're in London, it is in no way the least. Thank you very much for your time. Everyone in the audience, thank you very much. And we hope to do more again, and we will be in touch. Thank you and goodbye.